Carol George, a third-year PharmD student. And for today's journal session, I will be talking about clindamycin versus Bactrim for uncomplicated skin infections. General overview. The main authors were Lauren G. Miller, Robert S. Dohm, Buddy Creech, and David Young. This article was funded by the National Institute of Allergy and Infectious Diseases and the National Center for Advancing Translational Sciences, National Institutes of Health. Background. Skin and skin structure infections are one of the many conditions patients will seek medical care for. Approximation of 14.2 million cases of outpatient visits are accounted for in 2005 and at least 850,000 hospital admissions. It is commonly seen in ambulatory care settings. The common factors that are associated with skin infections was MRSA. Furthermore, communities that have been exposed to multiple cases of MRSA-related skin infections, have not received different antibiotic regimens for treatments. The best course of treatment is to use clindamycin or Bactrim. Why? Because the medication is has a good cost, and it has a good coverage against MRSA and MSSA. The objectives were the efficacy of the medication as it pertains to skin and skin structure infections, to determine the safety of the medication, assess adverse effect profile for course of treatment. The trial design was multi-center, prospective, randomized, double-blind clinical trial. The location: 4 U.S. centers located: Nashville, Tennessee, Chicago, Los Angeles, and San Francisco. The inclusions of the trial were: patients were eligible if they had 2 or more signs and symptoms for 24 hours or more, such as erythema, swelling, local warmth, purulent drainage, tenderness to pain, or palpitation. Exclusions of the trial were superficial skin infections, a human or animal bite at the infection site, high fever, the presence of immunocompromising conditions such as diabetes, chronic renal failure, or morbid obesity. Subjects: there were approximately 524 patients included and intended to treat populations. They were further divided into 2 groups: the limited abscess group, so smaller abscess less than 5%, and a large abscess or cellulitis abscess greater than 5%. The main purpose or the primary endpoint was the one intention to treat population and the other in the population of patients who could be evaluated. Secondary outcomes were cure rates at the end of treatment and follow-up visits 1 month later. They were divided according to adults and pediatrics population. The cure rate among patients with either cellulitis or abscess or in combination. The follow-up: patients were seen at the end of treatment, at the test of cure, 7 to 10 days after the completion of the prescribed medication. The duration of the trial was 1 month or 40 days. The population: a total of 52.3% of the patient was male, 53.2% were African American, 40.3% were Caucasian, and 28.6% were Hispanic. The average age was 27.1 years. A total of 29.6% of the patients were children. Arms: 264 patients were assigned to receive clindamycin, but only 259 did receive. The administered dose was as follows: 150 milligram tab 3 times daily, and 260 patients were assigned to receive Bactrim, but only 258 actually did receive. The administered dose was 150 milligrams trimethoprim and 800 milligrams of sulfamethoxazole, administered as 2 single-strength tablets twice daily. The statistical analysis. So basically, the null hypothesis was that clindamycin and Bactrim would end up being at equal rates. Study was designed as a superiority trial with 80% power to detect an absolute difference between the 2 treatment groups of 10% in cure rates in the population that could be evaluated at an alpha level of 0.05, assuming a 20% attrition rate. So the baseline or results characteristics: the female receiving clindamycin were 129 and Bactrim was 121. The race or ethnic profile were African American 141 under clindamycin, and African American receiving Bactrim were 138. As for Caucasians, only 102 received clindamycin and only 109 received Bactrim. As for multiracial, 10 people, or 3.8%, actually received clindamycin, or 4 received Bactrim. For age group, it ranged between anywhere from 1 to 18, specifically broken down 1 through 8. 45 people received clindamycin and 42 received Bactrim. Ages 9 through 17, 30 received clindamycin and 27 received Bactrim. Patients greater than 18, 183 received clindamycin and 186 received Bactrim. There were 3 types of lesions: abscess, cellulitis, and a combination of both. As for abscess, patients presenting with abscess, 80 people received clindamycin and 80 received Bactrim. And the list goes on. The primary endpoint. The rate of cure in the intent to treat population at the test of cure site visit was 80.3% and 95% confidence interval, 75.2 to 85.4. In clindamycin group and Bactrim group, 95% confidence interval, 72.3% to 83.1%. And the rate of cure in the population that could be evaluated, 89.5%. 95% of the confidence interval, 85.2 to 93.7. In the clindamycin group and 88.2%. In the Bactrim group, there was a difference of 1.2%, so a total of the p-value equaling 0.77. The secondary endpoints. The cure rates at the 1-month follow-up visits were similar for the clindamycin and Bactrim groups in the intent to treat population, 73.1%. and 176 of 260 patients in order. Further, in the population that could be evaluated, 193 of 230 patients, 83.9%. The difference about 5.7%. The equivalent to p-value equaling 1.15. The adverse event of the medication, most commonly noted ones were diarrhea, nausea, vomiting, pruritus, and rash. So the author's conclusion was there was no significant difference between clindamycin and Bactrim with respect to either efficacy or side effect profile for the treatment of uncomplicated skin infections, including both cellulitis or abscess. Also in children and adults with few or no coexisting condition. Critique. The strength of the trial was that it was double-blind, randomized clinical trial accompanied by detailed drug accountability, handling, and dispensing of study drugs. Furthermore, a detailed systematic review of adverse drug effects and the relatively low rates of attrition, 10.5%. Study also included children and adults because both age groups have high prevalence for skin infections. Lastly, the populations studied were ethnical and geographically diverse. The weakness of the trial. First, the study excluded patients with serious comorbidities which have altered the results of treatment with clindamycin or Bactrim. Second, only 2 antibiotics were examined. Third, a follow-up visit only 1 month after therapy was done. Staph aureus infections are recurrent and may need more than 1 follow-up. Fourth, dosages of the antibiotics of skin infection were not well defined. Lastly, isolation based upon Staph aureus isolation was resistant to clindamycin and Bactrim. To summarize the primary literature, the highlights or key points of this article: a total amount of 524 patients were eligible for this trial. It was conducted by separating the patients up into 2 main groups. First group included patients with larger abscess or cellulitis, and the other group included patients with smaller abscess. Patients selected had either abscess, cellulitis, or a combination of both. Patients were randomly assigned to receive either clindamycin or Bactrim for 10 days. Both the patients and the investigators were unaware of the treatment assignment and the microbiologic test. The conclusion of the article. To conclude, there was no significant difference among the treatment groups in either the intention to treat population or the population that could be evaluated, consisting of subgroups of children and adults. As far as adverse effects, both groups on either clindamycin or Bactrim had the same overall side effect profile. This study, in my opinion, was conducted well due to there being no bias and follow-ups with the patients. Likewise, medication was affordable and had good coverage against MRSA and MSSA. The trial did target areas where MRSA is also most prevalent. Lastly, I feel that the next time the study should include patients with a more serious skin infection coexisting conditions and to expand the testing of antibiotics. Thank you.